This next case is a giant fusiform basilar trunk aneurysm managed with flow diversion techniques. This is a 75-year-old male who presented with subacute onset of dizziness, diplopia, and blurry vision. His exam confirmed these findings, and his past medical history was significant for hypertension, diabetes, coronary artery disease. His CT scan, MRA, and MRI showed a large fusiform basilar aneurysm. As you can see from the angiogram, this is an ominous aneurysm, which is large and fusiform. The 3D reconstructions demonstrate there is compression of the aneurysm from the brainstem. Based on these findings, and based on the configuration of the vertebral artery relative to the subclavian artery, we elected to use upper extremity access. Here you can see from the three-dimensional rotation, we are attempting to visualize the aneurysm as well as the parent vessel. We are attempting to define the vasculature, the branches, and the configuration of the aneurysm relative to the basilar artery and the vertebral artery. You can see that the base of the aneurysm incorporates both the dominant vertebral artery and the non-dominant vertebral artery. Again, given the configuration of the vertebral artery relative to the subclavian artery, we elected to use the radial artery approach. It is important that neurosurgeons who perform endovascular techniques become familiar with both brachial and radial access, as oftentimes it is quite a struggle to access the vertebral artery from an aortic approach. Here you can see we're advancing the guide catheter over the 035 glide wire. Specifically, we're using the VTEC, an 038 glide wire, and a guide catheter, which we advance as a complex. We can see from the angiogram that the vertebral artery in the cervical region has some significant tortuosities, and we want to be careful to position the guide catheter in such a way that it's not kinking or occluding flow in these tortuosities. Now you can see that we're advancing the guiding catheter over an intermediate catheter around the glide wire. It is important to get distal access, especially when delivering flow diverters, as it often requires significant force to deliver these devices, and we want to prevent herniation of the guide catheter into the subclavian artery or into the aortic arch. Once we have distal access with our guiding catheter, we now bring up the microcatheter through which we will deliver the flow diverter. Here you can see that we've delivered the microwire past the fusiform aneurysm into the parent vessel. The microwire is now going out a branch vessel, and the microcatheter follows. The microcatheter needs to be positioned well distal to the aneurysm in order to deliver the flow diverter. Experienced users would know that often delivery of the flow diverter would cause prolapse of the microcatheter, and often that will result in too proximal of a delivery of the flow diverter. Therefore, we often like to deliver the flow diverter more distal than we anticipate, as often there is some prolapse. Initially, we like to say we use the one and done technique. In other words, we like to size the flow diverters to the appropriate size that we will cover the aneurysm neck with one flow diverter. We try to avoid double or triple coverage to avoid occlusion of perforating vessels. Given the size of this aneurysm, however, it is going to be almost impossible to cover the entire extent of the aneurysm with one flow diverter, as these often prolapse and often compress. As you can see in this case, the first flow diverter did prolapse and is now more proximal than we anticipated. It is covering part of the aneurysm, specifically only the proximal portion of the aneurysm. As you can see, we've maintained wire access at all times, which is quite important if we're going to deliver a second flow diverter. While maintaining the wire access, we brought our microcatheter back through the deployed flow diverter and positioned it again well distal to the aneurysm. Now we'll remove the delivery wire of the flow diverter. And once we've successfully removed the delivery wire, we will then bring up a second flow diverter and telescope it through what we've deployed and create an extended construct. One can already appreciate that there is stasis in this aneurysm. Here we can see we're bringing in another flow diverter. We have telescoped it through the proximal flow diverter, and now we will be deploying it even more distal than we had done originally. Here we can see deployment of the second flow diverter in a distal position. We are attempting to release the nose cone of the flow diverter and are waiting patiently for the flow diverter to open. Occasionally we will wag the catheter or create forward energy on the catheter and now express the flow diverter as opposed to unsheath it. This again prevents unnecessary prolapse. Here we can see we have ample coverage of the aneurysm both distally, and we continue to open the flow diverter into the flow diverter that's already been deployed proximally. Here again you can see we are expressing the stent rather than unsheathing. We have significant forward pressure or forward energy in the microcatheter, so we can balloon the stent and have it opposed and opened against the formerly deployed stent. Now we remove the entire construct, meaning the microwire or the delivery wire and the delivery catheter, and we will obtain final angiography to confirm apposition of the flow diverter in the parent vessel and the aneurysm. Here we can see intrasaccular flow stasis, which portends occlusion of the aneurysm. Additionally, we can see that there is ample coverage both proximal and distal and patency of the branches. 6-month follow-up non-invasive imaging shows occlusion of the aneurysm and patency of the parent vessel.